Endometriosis happens when you've got a similar tissue to the endometrium, which is inside your uterus, but it's on the outside of the womb.
Most people don't even understand what it is.
So when it sheds, it's got nowhere to go.
And that's where the problem begins.
So it sticks to your organs, and then it can spread. If it's been found on the brain, it can be found when it's on the lungs.
This isn't just bad periods.
I had it on my kidneys, I had it on my bowel, I had it on tendons, spinal nerves.
This is real.
They don't really know enough about endometriosis.
And that's the scary part.
If you eat more than 2 portions of red meat a week, you are 60% more likely to get endometriosis.
The things you do every day might be making it worse.
Hello humans, welcome to the MWORK podcast brought to you by Martin. That's me. Today I'm joined by Karen.
Hi.
Sharon.
Hi.
People can recognise the voices when they listen. Thanks for joining us today. We're here to educate, and hopefully talk about the support group you guys run. So it starts with, or the conversation is going to be about, or mainly about endometriosis. However, and we were chatting just before we came on air there, I wanted to do a bit more research myself, and I suppose being a male, my knowledge is certainly less in that general area. So I thought it was a good opportunity maybe just to set the scene about my educational journey, I guess, that I've been going on. Not talking about endometriosis, but setting the scene in regard to understanding, I suppose, cycles and pregnancy. So obviously we're here to talk about humans, and that's a monthly cycle, 9-monthly pregnancy. So then I was thinking to myself, out of curiosity, really, why a month? Why is it a month? And why 9 months to produce? So in my research, thank you ChatGPT, it then compared to it gave me comparisons compared to dogs and rats, which I believe one of those two are potentially quite highly compared in regard to certain researchers anyway. So I appreciate that potentially not like there's other animals we could look at, but they're the ones they picked. So a dog, which is on heat twice a year, so and then it goes through like a 2 months of pregnancy. So I was then thinking, why is it only twice a year when we're once a month, or humans are once a month? And it was saying that dogs are pretty robust animals, they have reasonable size litters, and therefore the need to repopulate, 'cause that's what it's all about, isn't it? Is less so. Rats, 3 to 5 days, they're on heat, I'm sure it's a different term, and then they give birth within a month. 6 to 8 in a litter and re-go, so they produce potentially 60 babies a year. So they're evolutionary, that's because they're just approaches a volume perspective of volume, and then obviously bring it back to humans, which is that monthly cycle. 9 months is kind of almost a year type of cycle, really, at that point. And then I was looking at other quirky ones, so you probably know this, and I learned this years ago, seahorses.
Yeah.
Male,
Yes.
that gets pregnant in that scenario. And then I was looking at, again, within 9 months, what's longer. So like whales are up to 2 years they can be pregnant for. You're nodding, so
Yeah.
Horses are, you'll know then, about 11 months, 12 months, they're on there. So again, I was thinking, why longer? What's the length to do with it? And like, humans, because they're so complex animals, that's the 9 months. But then I thought, surely our brain's more complex than perhaps a whale. So that's, well, who knows, yeah.
I don't know.
We're all killing ourselves, we're probably more stupid than whales. And by sheer size, and guess horses is the same, it's a complex. And then humans, as they're born, they have a very, very long period where they need to be with their parents, where the animals we've talked about can be self-sufficient, certainly quicker than that. So if that's setting the scene around cycles and pregnancy, we then talk about the cycles of women or ladies, and that's through a month. So again, nothing I knew, to be perfectly honest, or thought about, but the uterus during that month is getting ready for impregnation. It's creating a lining on the inside of the uterus called the endometrius, I think.
Endometrium.
Yeah, endometrium on the inside. And then the period, I guess, among other things, is the release of that tissue during that month. So that endometriosis, everyone's nodding, feels like I'm learning. That's what we're here to talk about today, and what there's obviously challenges with that, not only around the uterus and the womb, but wider the body as well. So if I've not messed anything up,
I think.
So then if we talk about sort of endometriosis and that, I guess you guys also have stories and experiences and challenges around that as well. But perhaps if we continue with the what I call an education, but discussing the detail of it, I'll hand over to whoever wants to get going.
So endometriosis happens when you've got a similar tissue to the endometrium, which is inside your uterus, which then spreads or passes out of the body. When you have endometriosis, it's a similar tissue, but it's on the outside of the womb. So when it sheds, it's got nowhere to go. So it sticks to your organs. Generally, it starts at sort of the reproductive organs, and then it can spread. It has been found in the eye, it's been found on the brain. More severe cases can be found when it's on the lungs. That causes some severe issues like collapsed lung and stuff like that. I had it on my kidneys, I had it on my bowel, I had it on tendons, spinal nerves, hip area, abdomen wall. Your placements were?
I had what's called ovarian endometriosis, or I still have that because even if I've had surgery, it doesn't go away. So I had endometriomas. I had what you would call, I suppose, the simplest way is C-section endometriosis. So I had a C-section when I had my son, and because of the surgery, those lesions were then transferred into the scar tissue. So it's quite a common area for that to then grow. I had the pouch of Douglas, which is
Yeah, I got to.
which is the Douglas.
Pouch of Douglas.
It's part of your anatomy. Within
It's basically the void down. So it feels to me like it doesn't stick to an organ, so it just falls into the void that is like down here, and it's called the pouch of Douglas.
Down here, as in
it's within your reproductive, reproductive.
Okay.
Area. Like
it's a really
pelvis.
It's a really common area for endometriosis to be. If you look at people's notes or records of what they say, lots of people have that within the pouch of Douglas. Obviously, I had it there, and then actually the front of my uterus was quite fine. That was okay. It was just obviously the C-section scar, and then I had.
Is it attracted to that then because of?
So when I had my cesarean, what will have happened is when they were doing the surgery, I didn't have a diagnosis at that point. I didn't know I had endometriosis. What will have happened is the surgery was happening, and because they didn't know there was endometriosis there, it was transferred in the sutures.
Okay.
Because obviously I'd been opened up, and you go through all of those pelvic walls to get in there to get the baby, and then you have to be stitched up again. What is interesting, actually, some research I was reading by the American Gynecological Society is now that they're saying that when women have a cesarean, they've done some research where they don't stitch up the uterus, they just stitch the other areas, and actually that's reducing the incidence of endometriosis in that area, because what it does then is it impacts fertility, and those are one of the reasons they were looking at it with regards to obviously the impact on cesarean sections and the fertility post that.
Okay.
And endometriosis is one of the things that came up, and what they found is not stitching up the uterus. Obviously I'm not a doctor and I'm not probably using the right words, but there wasn't really any more blood loss. So
You itself then,
I'm presuming so, because this is just some research that I was reading briefly. So I'm presuming that they're going to do more research into that, and maybe then eventually in the future that will become more of a given when it comes to cesarean sections. Basically, I had C-section, endometriosis on my ovaries. They did a uterolysis, which is where you release the uterus, the tubes to the kidneys. I didn't have it on my kidneys, but that had to be freed because it was getting blocked because of the endometriosis. I didn't have it removed within my bowel, but it was shaved off from the bowel.
Okay. So the tissue, and we go back to the tissue, which is perfect was the line of the uterus, but there's tissues outside of that space.
Yeah.
Genetics, why is it doing that?
So basically they don't know whether it is there when you're born. So I can't think of the word when it's develop when you're in utero.
Okay.
Because 5% of all cases present pre-menarche, so pre-puberty. So you've got to ask yourself why that's happening. So congenital's the word. So they think that it could be congenital. So you get the tracts developing in utero. And what generally is then making them, I suppose, alive and be a problem is believed to be obviously puberty.
Hormones.
Yeah.
Hormones.
Yeah. But there had been a case study where a 6-year-old girl had ovarian endometriosis and had to have them removed. She had stomach pain, and obviously, generally, that wouldn't be looked at. It's like, how would you find that? Well, obviously, she had a scan, and then obviously that showed up, but you wouldn't expect to find that in a 6-year-old. So they don't really know enough about endometriosis to know the real origins and
because
why.
the other thing, there's tests that also show, so I do a lot on diet and fitness and how to sort of holistically support yourself when you are waiting for surgery. Because I feel that sometimes the options that you're given, they weren't suitable for me. I didn't want to be put in a chemical menopause. I didn't want the side effects that come with a chemical menopause. So I looked at how I can support myself without the need of sort of synthetic hormones. And it can work really well. But one of the things that I found while I was researching is if you eat more than 2 portions of red meat, and it's not necessarily sort of low fat mince type thing, it's more like, obviously red meat covers bacon, sausages, steaks. If you eat more than 2 portions a week, you are 60% more likely to get endometriosis. So it is also something then that you can
What's the correlation?
develop hormones again. So we obviously pump cattle and stuff with hormones. Even organic to a certain extent will get hormones. They just won't be of the synthetic nature. And there's a lot more strict guidelines of how you can do it. So obviously you've got antibiotics, you've got hormones, obviously, you know, other places. UK is quite heavily regulated, so it's not quite as severe in the UK, but obviously there's a lot of stuff that goes in there. And it is the fat content, the blood, the heme iron as well that causes the problems, which is, they call it the iron paradox then, because obviously you actually, generally when you've got endometriosis, you are also generally iron deficient because you have heavier periods. You're obviously internally bleeding every month as well. It's not just what you want.
Heavier periods.
Because of estrogen dominance. So endometriosis is an estrogen dominant condition. And basically it's because your estrogen is at a higher ratio to progesterone. So like when Sharon's talking about the importance of nutrition and everything, that really obviously comes into consideration now. Obviously the reason being is, like she's saying, with the red meats and stuff, but I suppose if you look at it from a genetic perspective, like you're saying, what we need to understand is why some people are maybe born with the propensity to have endometriosis, but they don't develop it to the point where some people develop it. And because obviously there's different stages of it, but some people, so what's interesting is they look at research, and what they don't know is why some, like I say, some people have very mild symptoms, some people have really severe symptoms, and some people might live with it their whole lives and not even know, and it's not affected them in any way, and it's the disease hasn't progressed. So what's happening there from, I suppose, then you have to go down an epigenetic perspective of, you've got the genes, but what has the environment done, which is where the nutrition comes in and where other things come in, like trauma, stress, all of those different types of issues can impact. So like women with endometriosis are more likely to have what's called a connective tissue type disorder, or there's a high propensity for a diagnosis on the neurodiverse spectrum. And connective tissue disorders are also linked to neurodiversity. So those are all genetic factors. And then you look at endometriosis and where that comes in. And I don't know enough about connective tissue because I'm not a doctor, but if you think about the fact that that's to do with, I suppose, if you know, do you know what a connective tissue disorder is?
No, it's not.
Okay. So a connective tissue disorder can be, so the most commonly known one, but isn't commonly known, is a disease called Ehlers-Danlos. And a person can have many different types of symptoms. It can affect their cardiac. It can affect, obviously, their muscles and joints. They might be more flexible. So I haven't got a diagnosis of Ehlers-Danlos, but I know that I'm hypermobile. So if you look at, okay.
So bending,
Yeah,
backwards, etc. For those listening.
But it can affect any part of the body. So with regards to endometriosis, I've not read why that is, but you think, actually, why are those lesions growing? Is it to do with the connective tissue? Is it not strong enough within those areas? I'm sure there is somebody out there who knows about that and is researching it, but it's more common. And then what's more common in those women with those conditions, along with endometriosis, is the estrogen dominance problem. So then we need to look at how we balance that estrogen to progesterone ratio, but it's not just about estrogen to progesterone ratio, it's about your thyroid, your insulin and all of that, and how you balance that. And that's where the nutrition comes in. And that's where, if you support your body to have the right nutrition and feel safe, and then we talk about that not just from a nutrition perspective, but we talk about it from a nervous system regulation, so trauma. If you get those things right, you can help your body to regulate your hormones. Without those things, you can't. Does that make sense? So it might sound a little bit complicated, but all of those things have to come into place. And some people with endometriosis, some women, I'm not saying everybody's got trauma, because I don't think I have, not that I know of any, but I know I've got the connective tissue. And if I look back at history in my family, nobody else has technically got a diagnosis, but actually if I look back on my maternal side and I look at the history, and from what I've learned, I can see that actually there has been things that would suggest that that is an issue. But again, then you go back to environment, and what's changing the environment now, today, or from when I was conceived, to when my mum or my grandmother was, that has made this disease progress. Because today, although it's getting better identification, people didn't seem to be struggling the same with these hormonal imbalances.
So there's been an argument, I guess.
Diet.
With a lot of diseases. It's environmental.
Yeah, environmental, diet, exercise, what we did and what we don't do nowadays.
I think we talked before.
Yeah.
A couple of days ago, you think it's just microplastics, and whatever it's doing now wasn't doing 60 years ago. So can we just dive into a couple of bits? Can we dive into symptoms? And again, male, kind of familiar, but I'm sure there's a wide range. But what are the kind of headlines that you see in your support group that you chat, and obviously you guys have experienced as well?
So obviously what you would mainly find people would present with is unbelievably painful periods.
So where, like, you hear period pains and you endometriosis, how, this is just a point of, like,
periods
conversation of going,
painful.
Yeah.
They shouldn't be painful. No. That's the top and bottom. That's the message that we're trying to get across, is that periods shouldn't be painful. Uncomfortable, might not feel great, but they shouldn't be painful. I've seen situations with myself where I have been walking along the hallway in my house, and then a pain has literally taken the legs from underneath me, and I'm on the floor. And I will be on the floor till that cramp, spasm, whatever's happening passes, and then I'll be able to get up. And it's almost to the point where nothing ever happened. Like, I will get up and that'll be nothing. You'll go, I read a little blog, which I did share about 18 months ago, I think it was. And it was basically a woman describing going to the toilet. And she said every curse word went through her mouth as she sat on the toilet, just trying to do a normal bodily function. She's sweating, she's crying, she's wants to go, doesn't want to go. And then after that, 2 minutes later, she washed her hands, leaves the toilet, and it's like nothing ever happens. So that's another thing. Painful, going to the toilet, it shouldn't hurt. It shouldn't hurt. Sex is painful. Fatigue, oh my God, the fatigue is just unbelievable. You describe it as like having a rock on your head, don't you?
Yeah, I mean, I think I started experiencing fatigue when I was about 13, and I didn't know what it was. That was my symptom, really, more than pain. And obviously in the early 90s, they weren't talking about endometriosis at all. And you didn't talk about periods, like, not like girls do now. So, like, I just remember this fatigue starting, and I can remember it being some holidays and thinking, what is wrong with me? Why don't I want to do stuff like I really want to, but I can't? And we'd gone away to stay at my aunt's, and I always liked going there and would always be out doing stuff. And I just couldn't get out of bed. And it was like somebody was getting my head and pushing it back down onto the pillow. Like literally, I would want to get up, but I couldn't. I wouldn't say the fatigue was always like that, but it would flare. It would go through flares.
And do the flares coincide with cycles or?
Yeah.
They do, but
Not
not always. I would say
I
stress.
found mine do, and mine was always ovulation, which I'm
Mm.
most grateful for because that's generally over in 24 hours, not like a period, which can be up to 7 days. My worst, I could tell you exactly where my egg was. It was that painful when it was being released. I knew which side I was ovulating from. I knew where it was in my body because it was just so unbelievably painful. And I still, even now, I have had a partial hysterectomy, but not a complete hysterectomy. So I do still know that I'm not ovulating every month, but I do know when it happens. But for me personally, ovulation pain is so much more severe than my sort of period pains. But yeah, I was always grateful for that because it's 24 hours. But before I was actually diagnosed, I would spend probably 10 days a month on the bathroom floor. I either was so spaced out on painkillers and, I can never pronounce it, tranexamic acid and methylenic acid and various other things to try and prevent this pain. And I'd either spend 10 days a month in a tramadol haze, not knowing sort of where I was, what I was doing. So I couldn't work because I couldn't be in the car, I couldn't drive. I used to have to drive for my job back then. So I couldn't work. But then if I didn't take painkillers, I also couldn't work because I couldn't get off the bathroom floor because of the pain. So I was either on the bathroom floor in a stupor, but at least it felt like the pain was happening to someone else. I still knew the pain was there, but it felt like it was someone else's pain. But I had no idea what was going on then. Our daughter was 15 the other day. So it would have been 16, 17 years ago. So I would have been in my sort of mid-20s. So I kind of didn't have any idea. Obviously, I'd spent a lot of my teens on oral contraceptives, sort of the implant when that come out, and that seemed to be quite popular. So obviously my endometriosis must have been kept in check symptom-wise from the hormones. And then obviously we were trying for a baby. I'd had miscarriages, and that's why we went to the hospital to find out why I was kept having miscarriages. And I was infertile. So when I eventually got in for my surgery, so my fallopian tube was folded like a bendy straw, and the endometriosis had grown around it. And then I also had a lazy ovary, so my other one wasn't doing anything. And then the one that was releasing the egg was bent and it was stuck. So the baby would get to 7 weeks, which is where the endometriosis was. And then I would go through this almighty pain, which I assume is something bursting somewhere. And then I'd lose the baby. And it was always at sort of 7 weeks. And then I had Mr. George was my surgeon, and he released everything. I went on to have a baby. Well, I had a further miscarriage, and then I had summer. So, and then I was infertile again. Well, apparently infertile again. And then we had Jackson. It's now 10.
Yeah, that sounds pretty horrific. So we'll come back to your stories as well. So we then talked about the symptoms of it, the diagnosis side of it. And I think you mentioned maybe before we came on air, it's kind of something that's, say, 100 years, did you say at the beginning? But just talk about that, and obviously the evolution of obviously part of this conversation is to get more people to understand, and therefore I assume research really is in its infancy in reality, probably.
It's probably nil show zero, to be honest.
So start 100 years ago, it's...
Karen and I found Below the Belt. Yeah, and that's where a lot of our sort of knowledge into the research side of things, for me anyway.
What's that support group? What's that?
No, this is a documentary that was funded and supported. Hillary Clinton's part of it. Oh, what's her name? Jamie Foxx's wife, Corinne Fox. And who's the other lady that's massively famous that's involved with it now?
It's not
I
Oprah.
remember.
Oprah.
No, it's not.
No,
Oprah.
it's not.
That's Oprah talking about endometriosis.
So there was these three. I feel like we should find out who she is. But yeah, so they did this documentary. It's called Below the Belt, and it was about endometriosis, and it's obviously American, but it was one of the patients that they followed was a nurse, and she didn't know what was happening to her.
Okay.
Like, she's a qualified nurse.
Never heard of endometriosis.
Hadn't heard of it. And when they went through the textbooks, it was literally one line. In 7 years, medical training for some people,
Yeah.
it's one line, which is just so bad.
And it's still there now. It's still like
there.
that now.
Mm.
I mean, so there's very few specialists in the world for endometriosis surgery. If you're going to go for look at diagnosis, so it can take on average 7 to 10 years to get diagnosis. And if you listen to sort of Sharon saying about some of her journey and the things that you go through and how awful that is. Now, if someone is having those symptoms and they're seeing the doctor and the doctor's saying, "Oh, just keep going," that's not normal, is it? But it gets normalised and women get gaslit basically, and it goes.
It's often gaslit then. It's just period.
It's just periods. It's just periods.
With it.
Yeah.
Now, I need to put in here. So, my journey 16 years ago, I wasn't gaslit. I was diagnosed from onset of symptoms to my surgery and diagnosis was probably just over a year. It was on the Isle of Man. It wasn't private. It was through the NHS, and I cannot fault my care. Obviously, the surgery I now know was an incorrect surgery. It was the Isle of Man does ablation rather than excision surgery. So I know now.
Okay, so with regards to surgery for endometriosis, so when we're talking about
Can I just jump back?
Yeah.
So once you're diagnosed, is that diagnosed through scans?
No. So
Yeah,
so this all goes together. Right. So basically, to get a diagnosis currently, you have to have what's called a diagnostic laparoscopy. Okay. And that's what seems to be the given. But what we're working towards, what the specialists across the world are working towards, is diagnosis without that, diagnosis on symptoms, which, given the symptoms that women present with, if you meet somebody, because we've got endometriosis, and we meet somebody and they tell us about their problems, you know straight away, without any shadow of a doubt, that that's going to be endometriosis. And if it isn't, then there's something else seriously wrong that needs to be looked into, and they shouldn't just be left. So what happens with the diagnostic laparoscopy is you're often at a non-specialist clinic. This is NHS based. This is UK based. This isn't like America or anywhere else. And they will take a biopsy, and they will
Of what?
of the lesions that they can see, and they'll obviously be sent off, and then that will come back either negative or positive. But also, they don't always come back conclusive, and someone might be told that they haven't got endometriosis when they actually have. So when a non-specialist surgeon, so it's like a hierarchy of surgeons when it comes to endometriosis and definitely getting your diagnosis. So you've got obstetricians, gynecologists. Okay, so they're obstetricians and they're gynecologists. They treat women for pregnancy and for gynecological conditions. Endometriosis isn't purely a gynecological condition. It's an all-body inflammatory condition. And how it presents and looks can be different in different people. So if you're at a non-specialist and they look round, maybe even just the pelvic area, and they don't think to look up, check your liver, check up towards your thoracic area, all of those type of things, and they haven't taken a good history, and they say, "Oh, actually, no, you haven't got endometriosis, but you've got all of these symptoms, but no, you haven't. Goodbye." That's not a given, okay? But that's how that's how women are getting stuck and bottlenecked at the minute, because they're going to those non-specialists because they can't get to the specialist and they don't know to. And at the start of my journey, I didn't know that. I had to do the research to find out. So if you're very lucky and you have a diagnostic laparoscopy and you get a diagnosis, great. But what happens from there on? You haven't had potentially the surgery you need unless you've been at a specialist, which most women aren't going to get to straight away. So that's specialists. So basically, they do additional training.
No.
There's very few centres within the United Kingdom.
Okay.
Is it 5?
is it 5?
in the UK.
Yeah.
And there's a
Okay.
massive waiting
Yeah.
list. And you can imagine that quite a lot of those doctors who work in those units also do private as well, because obviously the need for that and the call for that is quite great because of what women have been going through.
And then to go back to the surgery, and there's 2 types of surgery.
Okay, so you've got your ablation and you've got your excision surgery. So the specialists will do excision, and some do it robotically, and some just do it with single stick, and they don't have the robot. And really, there isn't that much difference. It's the skill of the surgeon to know what they're looking for.
They're cutting the tissue away.
They're cutting it out rather than burning it, because if you don't cut it at the root, then you're just burning the top off and the rest of it's still there, and then you're just creating scar tissue. Now, even if you go to a specialist though, right, we have to make this quite clear, even if you go to a specialist and they remove all of the endometriosis that's there at the time, that doesn't mean that you might not get new endometriosis, okay? And fingers crossed you don't, but there isn't enough. They haven't been doing that type of surgery for long enough to know what the outcome is.
That's where, again, diet, exercise after your surgery. And again, it's very similar that, again, everything I know, I've researched myself. I've never been. So one of the questions I asked in one of the Manx care appointments was, is there any diet information that you can give me that I can support myself? No.
And your surgeries, that was part of that process.
And this was a long time ago. So Mr. George has been retired for quite a while now. But I was originally seen by Mr. Ghosh, and he just arrived on the Isle of Man at the time. And I say he told me, I think after my second appointment, he suspected it was endometriosis. When he did a laparoscopy to look at it, it's the only way that they can diagnose it. And he seemed very...
So is that scope? How's that?
Yeah, it's a,
So they go into your belly button.
Okay.
and other areas, and they blow you up, don't you, tummy up, and
You inflate it like a balloon, basically. And it's not pleasant.
Mm.
So I'd say I was really lucky. I was a year. That is generally unheard of. It's not everyone's story. I could just say I was really lucky. So I also think though that my journey obviously changed, because then I did have a baby. And that's sometimes that's the advice, go and have a baby. So you don't have a period for at least 9 months. So obviously while you're not having a period, your lesions aren't also having a period. I think there was possibly misinformation that maybe your body would then break the lesions down. But then obviously if you also breastfeed, you don't have a period while you're breastfeeding. So I went probably about 18 months without a period. And then I was back on contraception. So then again, that would mask any symptoms. And then we went to try.
That's balancing that.
Yeah. So again, that
it is the progesterone ratio. So when you're pregnant, nobody could ever assimilate the progesterone rate that you have when you're pregnant. You're never going to get that. And that's why most women feel quite good, especially in the 3rd trimester of pregnancy. And why women with endometriosis, if they can get pregnant, do, because the progesterone has balanced out your estrogen dominance. So it's not a cure, it's just that your progesterone has been balanced out.
It masks everything that we've got at the moment, except for excision surgery, masks the symptoms.
Yeah, okay.
And there's a danger of masking the symptoms. I'm not for the sort of synthetic hormones and stuff. Obviously, sort of 15, 16 years ago, I didn't know what I know today and the damage that they can do as well. But I am all for, if you need to stop the pain and they're your options and they work, then take them. But the thing is, what seems to be happening is they're just left on them.
Yeah.
No one's then doing any checks. Your pain stops. You feel a bit better. So you're going, oh, these work. They haven't cured the endometriosis. So
is that it's called a tablet, probably a bad term, but is that different from the pill, or is that the pill just a variation where it's...
So there's the pill, so you can be offered the pill that I can never remember, GnRH, which is the chemical menopause. Then you've got the new version, which again is just the chemical, which is just it's got HRT built into it, basically. That is a tablet form. Then you've got, it is basically the progesterone only pill is probably one of the best ones. And the probably the most likely one. If I was to have to take something now, I would probably go for the Marina coil. If I was going to make a decision, if somebody said you have to take something to manage
Just balance
this,
that.
the Marina coil would probably be
A lot
what
of,
I would go for, and a
a lot of women are going with.
success managing symptoms with the Marina coil.
So we go back 100 years and the research into it. I'd assume there's more cases now. See some more conversations happening. Is the rise in cases because, well, why? Because I'm sure there could
So
be.
you've got to, when we were talking about genetics before and the environmental impact, I'm not saying this for definite, but I would say that we live in a very different way than we did 100 years ago, even. So I'm not saying endometriosis, it wasn't there then. But when we look at epigenetics, it's the environment that loads the gun that causes the problem, which then causes, obviously not just endometriosis, but we look at other chronic diseases, and this is a chronic inflammatory condition. So then we have to ask ourselves why some people's progresses and some people's doesn't. And still women aren't getting diagnosed to the rate that they should be. But I can tell you from standing in the school playground, once people knew what me and Sharon were doing, the amount of people that would come up to you and say, oh, I was told I had endometriosis, but it's not really a problem. Or I think I've got it. Yes, and I think I've got, and I think I've got it. Some people don't get diagnosed till menopause. Some people at fertility, obviously.
So it can be asymptomatic.
It can be asymptomatic. But if we're going back to, what was it? Why
100 years ago, like with the research.
Yeah. I mean, I see people talking about more. I guess the numbers
so many,
that are going up.
Yeah.
Albeit more people are checking. We also know what it is, but also, I'm sure
there are many different factors in our environment.
Confidence in talking out.
Yeah.
Like a woman probably trying to work out 1920 something, isn't it? A woman wouldn't have spoke out about that. Like she wouldn't. And I did some research for a blog post that I did do for my job about some of the stuff that women put through in tests, and I have to laugh because otherwise I'd just be crying in the corner. And hysterectomy comes from hysteria, and like basically that time of the month. If you look at some of the research that I did for it's basically women in STEM that I research and I do the blogs on. And one woman was prolific in women's health, and she was one of the first women all those years ago to say that actually the problem could be the man. If you can't get pregnant, like that was just, like that didn't happen. And she was one of the first, she was the first woman to say that medically in a journal that the problem can be with the man. But when you actually look at some of the tests and stuff that they were doing, obviously this is thousands of years ago, not 100 years ago, but obviously hysterectomy and stuff comes from hysteria. That is the name, because they said that.
Well, women didn't have rights, did they? And if the husband decided that they were mentally unstable, they could get them put away, couldn't they? And there you go.
Not life assumes it wasn't that long ago.
No,
it's quite scary in fact. But I think it's just people having the confidence to speak out now. Obviously, that menopause is being put on the table quite a lot more as well. So women are becoming less embarrassed to talk about it. I mean, I know for a fact that 15 years ago, there's no way I would just sat here and spoke like this about it. I just spoke to my closest friends, but there's no way.
I don't think there would have been access to the information either.
Okay.
I'm saying with ChatGPT search,
and what has grown in the last even 10 years is functional health and nutrition, and actually more people looking at also naturopathic and herbal support. And this is not me saying you should do this, you shouldn't do that, but what we've lost along the way is we're very much focused on what you call mainstream medicine, but we've forgotten about what we used to do, and those things must have worked. And there is, I think, a place for both, but we need, and when we're looking at how we support our bodies, we need to think, well, actually, was the human body that stupid that it couldn't actually deal with these things, and why are these things happening? And I know I said about genetics again in the environment, but I do genuinely believe it goes back to that. And I think there's two factors. There is more education, we've got access to it. But I do think that we don't have to accept that this is becoming more of a norm. Because you hear about more teenage girls, and yes, I did have the symptoms when I was a teenager, but some of the girls I'm hearing about, I'm thinking that's absolutely horrendous that a child that age is that unwell. And yes, you can have the surgery, although it's really hard to get access to treatment when you're like a teenage girl, but you're never too young to have a diagnosis of this condition. But why is it happening? Why have they got that ill in the first place? And yes, we can have the surgery. Our group really is born out of helping people access the gold standard treatment for surgery so that they're not getting the wrong types of surgeries. But even post that surgery and waiting for that surgery, we need to be asking ourselves, what's at the root cause of this disease? Why is it such a problem in our society? And it's got to come down to...
So much research spent on it.
No. But if you look at research in general about genetic profiles that are getting done now, and people can go and they can get their 23andMe done and things like that. But then you've got other practitioners who are more like skilled in genetic profiling. And they can do you a full report of what your genetics are and how they all work together. And I'm sure, I mean, I'm no expert, but I'm sure lots of people have heard of people going on about methylation and MTHR and all of that. That's all sort of more out there. But that's just like, that's very, very complex as well. And most of us do have MTHR, and it's not a diagnosis, and it's not saying that this is a problem. But what we need to understand is what's happening within our genetic makeup, within our environment, that makes that a problem. And methylation is a problem when you look at endometriosis, because obviously we're not methylating correctly and metabolizing.
What's methylating?
Methylation, oh gosh, I don't know how to explain that easily. So methylation is how you process, I mean, I'm not a nutritionist, but from my understanding, it's how you process sort of your nutrients within your body and all those types of things.
Yeah, because I've seen where you can send blood samples away and they can tell you you're not great at absorbing iron, think about
Those
these
types
other
of
ways
things.
to do that, for example.
Yeah. And all of the hormones, like I said before, they need to work together in harmony. So to do that, you need to have, like I said before, the right nutrition, the right nervous system regulation, and the environment around you needs to be
The other thing is why certain, so like I had the coil. There was on this ITVs this morning, and I remember Dan phoning me and saying, put this morning on. Now there's a young girl, she was only young, she was at school, she was on the TV in her uniform, she was talking about having a coil, but now it's magically changed her symptoms from endometriosis.
Was that byproduct? Because she just...
So it's progesterone only. So obviously it raises then your progesterone, which will balance it out against your estrogen. But obviously it depends how out of whack your progesterone is to your estrogen. If it's not touching the sides for the gap, then it's not really going to work. So it does work for some people. But I was on the coil, and then they put me on the pill, and then I had to take another thing because I was neurotic. I was actually neurotic. It was nuts. I would be driving along the road crying, absolutely no reason whatsoever. It was just insane. And then with everything, all the extra, then I was taking this tablet and I was taking that, and I was like, what am I doing? Like, why am I doing this? And then there was talk to put me on antidepressants, and I was just like, it's all because I've got a painful period. This is crazy. This is just... It's over medication.
It is, because the mainstream approach within medicine, which I think personally I believe needs to change, is we look to mask symptoms. Whatever the problem is, we don't look at why. We look at, and then you take one medication and you need another and another and another, and it causes other problems. And when it comes to like hormonal suppression, really, because that's what synthetic hormones are, you're then impacting your ability to absorb certain nutrients, because those hormones, those synthetic hormones, impact that. So then you're adding into a body that's already got problems, even more problems with absorption, nutrition, etc., etc. And one of the things that goes along with endometriosis is thyroid problems. It's really, really common, and other autoimmune conditions. Endometriosis isn't seen technically as autoimmune, but they think it could be, because obviously it's associated with lots of others. But as I said before, when you're looking at hormones, you're looking at your progesterone, your estrogen, your thyroid, and your insulin, and those all need to be lined up for your hormone balance to work. So, like, I take a bioidentical progesterone, which is very different to a synthetic progestin. So progestins are different to progesterones that are bioidentical. So bioidentical is a micronized, so it's as near possible to be similar in molecules to the progesterone that your body produces, whereas synthetic doesn't have that within it. So when you use a bioidentical progesterone, you're giving your body, hopefully, the balance to help with the estrogen, but that's not going to work on its own. You can take the bioidentical progesterone and think, oh, it's not working. Well, it's not going to work if you haven't got the foundations right. You've got to get your gut health right, your nutrition right, to make your hormones be working properly. And you need your thyroid to work properly for all those other hormones to work, your estrogen to progesterone balance. But then even if you're taking like a bioidentical progesterone, you need to get the dose right. And although endometriosis is an estrogen dominant condition, it doesn't mean that like my estrogen is like way sky high. It just means that my progesterone is underneath it, you know, and some people might need to dose higher and some people might to dose lower. But the best way to know whether that progesterone is working is on symptoms. You'll hear people talking about Dutch tests and having blood tests and stuff for checking hormone levels. Now, a Dutch test is, you don't just have to be a woman to have a Dutch test. Men can have them as well. But what it looks at is how you metabolize specifically, well, your hormones, but what it's specifically interested in, most women get it for, is because of how they metabolize their estrogen through their liver. So you have 3 phases of estrogen metabolism through your liver, and you need all of them to be working to excrete it. And if you're not excreting that estrogen, you're recirculating it in your body. And most women with endometriosis are recirculating that estrogen. So then it becomes a problem, and that's what obviously causes the lesions to grow. Now, you can get a Dutch test done, and that's a snapshot in time, and it does give you a good idea of which pathways are working. And then you can work on how you're going to support them and can get the right advice from the right practitioner. And that is really helpful. But what really gives you the answer as to whether that is all working, your nutrition, your progesterone and everything, is whether you've got symptoms or not. I can tell you, I have worked on nutrition and everything for nearly 10 years. I've had the best surgery I could possibly have that I paid for. It wasn't until I introduced the bioidentical progesterone and dosed it at the right dose for me, and it's not quick, and it changes over time because progesterone is neuroprotective as well, and so it doesn't just support.
So under medical supervision.
It doesn't just support regulation of, say, my endometrium to help with regulation of my periods, but it also helps with other symptoms that you get when you have endometriosis, because we talk about anxiety and fatigue and all of those types of symptoms. Because it's neuroprotective, it helps with all of those as well. And quite interestingly, I read recently that actually progesterone is protective of kidney function. And one of the problems that women with endometriosis have is obviously the endometriosis affecting their kidneys.
Mm-hmm.
So it can be...
It's a vicious cycle. It's a vicious cycle. It's finding what works for you, and that's one of the biggest problems I find is we give the medical professional a hard time. It's like 7 years to 10 years for diagnosis, but if you can actually be asymptomatic but infertile, how are you going to we say the most common symptom is pain, probably followed closely by fatigue. They're probably the 2 biggest symptoms, but actually if you look at my notes, there's several others that go with it. So it's obviously, it is difficult to diagnose. as well as the fact that you've got the professionals that don't listen, as well. You've got the medical gaslighting that does go on. It is documented, and it has been in front of Parliament.
Last year.
Last year it went in front of Parliament about the medical gaslight, and there's a girl's.
What's the outcome of that?
Well,
It's ongoing, isn't it?
Right.
it's ongoing.
Part of the
And I-
research of that.
Yeah, I signed up.
Parliament UK result.
Yeah.
Yeah, but basically, the girl who did it, Ray, she had endometriosis herself, and she wanted to look at the disparity of care across the United Kingdom, and so she asked for volunteers, and she got loads and loads of volunteers. She used 40 case studies in the end, and it's called Endometriosis and the Knowledge Gap. And if you look at some of her statistics, so one of the first things you're usually offered if you get through to sort of gynecology is to have an ultrasound scan. 85% of scans miss disease because the person who's doing the scan doesn't know how to read them to identify the disease.
Not that they don't know how to read them, full stop.
Well,
They don't know how to read
for endometriosis. And then 65% of these surgeries that might have followed from this missed disease.
They talk about it in schools.
No. And this is one of the things, obviously, that needs to change. But it needs to change in general for the whole population. It needs to be talked about more. I mean, everybody knows that, like, is it 1 in 10 people have diabetes? But when you say endometriosis, people look at you like, well, that sounds like some exotic rare disease. Well, it's not rare.
It's 1 in 10.
Yeah. And that's 1 in 10 of 50% of the population, not 1 in 10 of 100% of the population. And then those statistics are still under, because the only way it's recorded, like with the Office of National Statistics, is if you've had a diagnostic laparoscopy and it comes back. So
yeah, whereby I guess if you have the symptoms, they
Yeah.
give you the pill, it
Yeah.
gets rid of it, it doesn't
Yeah.
come in stats.
And
So,
you don't actually you don't
Yeah.
have
Yeah.
okay.
So I mean, do you want some more statistics?
Please.
So like
Nerd.
so with regard to the 85% of scans that miss disease, when 100% of those women then presented their scans for second opinion or third opinion with an expert, 100% visualised disease.
Oh, okay.
And 83% of cases of those people's surgery was then confirmed.
It seems a bit bizarre. Again, I appreciate every case is individual, but when someone's scanning and you're scanning for that issue, I thought they'd be reasonably better statistically that they're going to spot them. Appreciate it could be hard and
You
I
have
think it's very, it's very
why
difficult.
someone then untrained looking at it. Is that all?
This is something
Exactly.
that
Well, this is the problem, isn't it?
this is what we've tried on the Isle of Man, obviously not broad scope, but obviously a lot of people are trying to change that. And what I've had on the Isle of Man 4 MRI scans for endometriosis, and every single one of them says I don't have the disease. I went for 1 in Manchester, and they pinpointed pretty much to the millimetre exactly where they were. But that was
You
it.
had 3 surgicals.
I've had 4 surgeries now for endometriosis.
Scans, definitely.
So that, yeah, the scans, they work well. And what I say is, why are you scanning me?
Yeah.
Don't do it. It's look at the NHS as a business. You know that you haven't trained your radiographers to that level. So don't put them under the microscope like that, because they get a hard time, but they haven't been trained to look for it. Give that MRI to somebody that's more worthy of it, that would actually have a beneficial outcome. I believe our MRI, so I questioned this with Manchester. I spoke to them and I was like, how come I had my 3 scans? I was like, how come these 3, according to them, I don't have endometriosis? Yet your one pinpointed on my tailbone, it was here, it was there, they picked up previous, they differentiated between what was actual endometriosis and what they reckoned was prior scar tissue from previous surgeries and old endometriosis lesions. Like, that's how in depth it was. It was 2.5 pages of A4 what come back, not just one line, you don't have endometriosis. I remember going for my surgery thinking, oh my God, I'm wasting my time here. This is in my head. Like, this is insane that I'm going for this surgery that could actually be beneficial to somebody else's. And then I was told that there's a potential I might lose my kidney because of the disease. So, but the MRI said I didn't have it, but it was compromising my left kidney to the point where they said one of the decisions I had to make was to go privately, or they were going to do a kidney function test, and then I was going to make a decision if my kidney was already beyond repair, then the easiest solution would be to remove the kidney and the tube and take the disease away with it. But according to the MRI that I had 2 months before that, I didn't have any disease. So
What's the communication like with Manx Care?
we've got bad. It's not
It
bad.
fluctuates. I think it's dependent on practitioner, and I think that's where we have been trying to work with them to improve access to care and, I suppose, consistency across the board.
They have been more engaging though recently, but it goes up and down, doesn't it? Like sometimes they're very active, and then sometimes they're not. But obviously, I do wonder if a lot of it. Originally, it was 3 years ago, we were quite harsh to them on Manx Radio. And then obviously they approached us, did we approach them? I can't remember now, but we had a lot of the Spotlight on Women's Health, which was this whole new roadmap that they were looking at, and they were going to implement that. And obviously we were looking at the Isle of Man because it's so small, of revolutionising women's health, like do it on a smaller scale and then build out. If we can do it, then you sell that roadmap to other people. And we were involved in that. And then obviously I assume that the books come in, and
I think from the start, obviously, you're having any kind of strategy. A women's health strategy is going to take 10, 20, 30 years to start seeing change. And I think what happens is the staff changes, the funding changes, there's all of those types of things. And I think from the perspective of where we would be able to get impact and help women access the care that we want to help them access, because that's our primary goal, is to help women access the gold standard surgery and then educate themselves with everything else. That's what we need to work with Manx Care. Now, when you look at how you would do that in an ideal world, what you're doing is let's say, for example, if you needed open heart surgery, triple bypass, what happens? Where do you go? You go to Liverpool, don't you? Endometriosis surgery is as complex as that, because you could need a bowel surgeon, a urologist in with that endometriosis surgeon. You could need a thoracic surgeon. So you're never going to be able to do that here. And even if you don't need those additional surgeons, it's still complex surgery that we can't do. So why would you even consider doing it? So in an ideal world, is the path, we would like a pathway where the women get that referral straight to the specialist centre. They're evaluated in the specialist centre. We're not saying you're going to get through it quickly because there's a waiting list in the specialist centres, of course, because there isn't enough of them. But at least you're there, and you're not then 10 years to get there.
Yeah. So, I suppose the reference on our man would be cancer challenge, you're referencing to Clatterbridge typically. The specialist know where you go. So similar to.
Yeah.
And then you mentioned you think you said we being the support group.
Yeah.
So talk a little bit about where people can find you. And
so we have our group, it's Manx Endometriosis Support Group. It's mainly on Facebook at the moment. So join that. We are reachable. We do have an email address which we don't really monitor regularly enough to actually sort of give out.
But they can reach out through
the Facebook group.
It's easier.
I know that. I suppose a lot of the challenges, or not the challenge, but the good thing is to get people in that space, because then there's a lot of people that can obviously go into exactly the same thing.
That's
push harder here, think about this, whether it be your diet, etc., as well as then pushing the door.
It is a good space, and what we're seeing a bit more of now is it used to mainly be you and I that did the posting. We occasionally got a girl who'd said this has happened, that's happened, but it was mostly but now what we're seeing is, and it used to be very sort of time consuming to reply to everyone that comes through, whereas now what's really good, and what I've noticed with the last few posts, because I was shut down on Facebook just over a year ago, and it took me a little while, and since coming back on it, I don't use it like I used to. I'm not on it in the same sort of scope that I was. And it's nice to see, though, other girls saying what they've learned from us, and seeing them supporting the other group members, saying things that either they've researched for themselves or they've seen from posts that we've done previously. It has become like in the last 12 months, it's become quite a lot more like vocal with other members actually commentating. And I find also that even if there's somebody that doesn't speak on there, they're probably reading it.
Yeah.
And just knowing that they're there for them, being able to say that actually, well, if I ask that question, I'd probably get the same response. So it is nice to see
No, it definitely is.
how it's sort of changing, and it is growing.
Yeah, because we always give people the advice to link them in to another Facebook page, which is well known throughout the world, called Nancy's Nook Endometriosis Education page. And her page is purely for education. You don't go on there and ask questions. It has got a wealth of information about how to navigate the medical world in relation to accessing care. If you use that page properly and the website properly, you can get the information that you need. Nancy is a retired gynecology nurse who had endometriosis herself. She worked with a doctor who is like a pioneer for the type of surgery that women need today, because Dr. Redfine, he died maybe 2 years ago. And basically he was like the one who started this type of surgery, because before like laparoscopy, obviously the surgery would have been laparotomy, opening somebody up and removing the lesions. And I think from what I recall from when I've read information, because I do read quite a lot and then I forget
Everything.
is that he noted that what had changed, why wasn't the success rate in the surgery as good? Because actually then he realized, well, actually we're burning it off, we're not cutting it out. So she worked under him and he developed that, and this was just in a small town in America. And there is a doctor actually who works at St Mary's, Dr. Pickersgill, who also is private.
Under him. Wow.
He chose to go and work under him because he was working in Manchester, and he's like, why are we giving like 23-year-old girls hysterectomy? This isn't right. And actually at the time when he was trying to do that, he'll explain and he'll say, well, actually, I think he was reported to the medical board, the GMC, by his colleagues. But he was right and they were wrong, but they didn't want to. Anyway, obviously he's a fantastic surgeon, and he did link in to do some training for Manx Care for us in July. And you can just see what a genuinely nice person he is outside of being the doctor, and actually that he listens and he wants to do the best for the women that come under his care.
That was what he said, wasn't it? One of the biggest things. So what we did for that one is we did In Your Shoes, and we basically just read out, we had the stats, didn't we? And we basically just read out what our group had posted about how they felt in the care. And the one thing that does come out is nobody listens. Nobody listens. And he was saying that he's seen several women he come on and he said, like, I just want to say that basically I don't need to do my speech because you guys have covered it. But one thing I do find shocking still, even to this day, is by the time sometimes the women get to me, they've been through 3 or 4 different sort of people.
Yeah.
And they leave and they're crying, and he's like, are you okay? And they're like, I just feel like I've been listened to.
No.
And that's what I said the other day, wasn't it? One of the biggest things as a medical practitioner, if you don't have the sort of insight to endometriosis, if you've got somebody presenting with painful periods, with the fatigue, just listen. Don't discard them. Don't say it's in their head. Don't say it's normal, because it's not. That's the one thing that you can change instantly, is just listen to them. Just listen to what they have to say. It's not in their head. It is real. And it's not normal. And it's really not.
Thanks for coming in.
Thank you.
We'll put some links to the in the descriptions, and when we file around on socials as well.
Yeah.
And obviously, I guess the message as well is, if you think you've got symptoms and maybe they're not being listened to, whether obviously I'm sure it's not intentionally or not, reach out, and we'll, obviously through your own experiences and people you've met, you can. None of us the doctors are here. We can point and help in the right direction. And I love that coming into the holistic side of things. So I love that aspect as like, also there's an element of our own health, or all our health, it's our own responsibility.
Yeah, you have to look after yourself. I mean, there are obviously medical things that you can or need to do, but at the same time you are responsible for yourself. So you do need to also look into these things. One of the scariest reads that I've read recently is one of the Banchulicans, that ultra-processed people. That is a scary book,
Okay.
but at the same time really informative. And although it is not obviously dedicated to endometriosis, actually what you can take away from that is like the sort of anti-inflammatory diet. That's what I recommend to follow. But yeah, ultra-processed people is something that I do recommend that everyone reads.
Yeah. I mean, also like linked with easy things to access on Facebook, you've got Kitty Martone, who runs the Estrogen Dominance Support Group. She is known as Healthy Gut Girl. That's her other page. She actually has a really easy course that you can do. You can do she's American, but she has got she did have hormonal imbalances herself, but she's a naturopath, she's a functional health practitioner. You can do her $25 course, which is the easy introduction that gives you the kind of understanding of how to start doing that. And if you wanted to go on and do the whole thing, it's like just over $200, which obviously would equate to whatever in pounds. Because all this is about education. But her support group, the Estrogen Dominance Support Group, I would urge anybody with endometriosis or they feel like they've got a hormone imbalance to look into that page and to some of the information that Kitty has, because she has files on there which will teach you about estrogen dominance and why it's there. And she also links in a lot with a Dr. Carol Peterson. She is a compounding pharmacist, and you'll be able to find some of their podcasts on there, and they're really, really interesting, and they'll give you loads of information and really easy to understand information about hormones and hormonal support and nutrition.
Great. Well, we'll grab some of those links and throw them in as well. Appreciate your time, Karen and Sharon.
Thank you. Thank you very much.
It's a word out from all.
Poor flimsy humans. Don't you wish you were flawless like me? A towering inferno of physical perfection?
I hate to pop your blimp-like ego, but you're not perfect.